Hello, we are from Group 6. We'll be presenting a case study under the course of MDJ 3253 Complex Nursing Practicum. The course coordinator, which is Mr. Devnath Kaushal, under the title of Case Study of Patient with Dyspepsia. The authors, which is me myself, Muhammad Akidin bin Wardi, Nur Atikah, Nurul Batisha, and Nur Isma Anisa. Proceed with introduction. There's certain challenge that we face during this case study. One of it is that the patient was diagnosed with gastritis before being confirmed as dyspepsia. So it means that the diagnosis was unclear until this year. Then the lack of information on the specific treatments and management, because this is our first time encounter with this disease. What interesting about this case study is patient had multiple histories of hospital visits with the same sign and symptom, and we only got the opportunity to provide care to the patients at ETD.
Next, I will explain about the case presentation. For this patient, Mr. C is a 36 years old male Bidayo. He's a factory worker. He's not married yet and he lives alone without his family. And he was the eldest one out of 4 siblings. So Mr. C came to ETD Baru on 13 August 2021 at 7:30 p.m. via walking. And he was complained of having chest discomfort on and off onset at 7 p.m. with a pain score of 4/10. And at first he was only experienced mild burning pain at upper abdomen, but then the pain radiated to his chest and he realized that pain is a burning pain. Then the associated symptoms that present were mild headache, nausea and vomiting. And the pain would present when he was lying down, but then he tried to take analgesic, which is paracetamol, but it did not totally relieve the pain. So since 2016, patient was presented with the similar symptoms, and he first came to OPD Baru with complaints of having burning and pricking pain at upper abdomen, but he was never been admitted to ward because the doctor was assumed that he was having gastritis. And since then, patient was frequently came to ETD to seek for treatment. And patient did undergo endoscopy at private hospital about a year ago, but the result showing no abnormalities. And finally, on the 3rd August, patient has been diagnosed with the dyspepsia. Okay, next is the assessment. First is the assessment by the body systems. Okay, for the general inspection, I observed that patient appears well groomed. He able to ambulate without any difficulty. He has good posture, which is no kyphosis and scoliosis, no jaundice, and he has good speech pattern and clear voice intonation. So for the face, for the terms of eyes, his pupils are equal. The size of both pupils is 3+ and reactive to light, and there was no infections on both of his eyes. And for the ears, there was no infection on both of his ears. And the mouth, both gums and teeth are normal. Tongue is moist and he was wearing no dentures. For the integumentary systems, he has no history of skin problems. He has normal color of skin, good figure, and no edema or bruises. For the musculoskeletal system, he has full range of motions and there was no deformities on both upper and lower limbs. He was alert and obey to commands. His Glasgow Coma scale score is full, which is 15/15. And when he was breathing, he was not using any accessory muscles, not producing abnormal breathing sounds such as wheezing. And the capillary refill is less than 2 seconds. There was no clubbing or synostosis nerve. And for digestive systems, his abdomen is symmetry. It was soft and not distended and produced normal bowel sounds. Okay, next is the assessment, which focused on the complaining areas. There was 2 complaining areas, which is chest and upper abdomen. So for the chest, patient was complaining of having chest pain, which is burning pain, but other than that, there was no abnormalities on his assessment. So for the upper abdomen, there was no lesions. The color of his abdomen is normal. There was no jaundice. The abdomen is symmetry, soft and not distended, and producing normal bowel sounds. Okay, next is for the clinical examination. ECG was performed on this patient and the results show normal sinus rhythm and there was no abnormalities.
Now, I'm going to talk about the pathophysiology regarding this case study, which cover the normal process and the disease process. As for the normal process, I'm going to mention about the pathophysiology of the stomach, and as for the disease process, I'm going to mention on chronic gastritis, indigestion, and heartburn. So, normal process of the stomach. As food, or known as bolus, enter the stomach, the cardiac sphincter and at the cardiac region will prevent blood flow of the stomach content. So the food is then mixed with via peristaltic contraction with digestive juice, which are hydrochloric acid and pepsin. So the food, which in terms of chyme, then transported from the pylorus through pyloric sphincter into the small intestine. And then the pyloric sphincter will prevent backflow of the chyme from small intestine where further digestion and nutrition absorption occurs. So now I'm going to talk more in details about the gastric juice. So firstly, hydrochloric acid, which is HCl, helps to break down the bolus into liquid form, or known as chyme. So the pH of HCl is very acidic and it is strong enough to damage the stomach. Thus, to prevent the erosion of stomach lining, the mucosa produces mucus to protect the stomach from getting digested. Next is pepsin. Pepsin helps break down most of the protein in food into soluble protein or peptone. Chronic gastritis can be classified into a few categories. However, based on the case study, the disease most likely to occur due to overproduction of acid due to chemical irritants such as alcohol and nicotine from cigarettes. As overproduction of acid occur, the mucus unable to protect the stomach lining and cause erosion, and constant erosion finally led to inflammation of the stomach lining. The signs and symptoms are upper abdominal pain, bloating, nausea, vomiting, belching, loss of appetite, and weight loss. Patient does show similar signs and symptoms for chronic gastritis. However, medical diagnosis remain inconclusive as no abnormality detected from endoscopy result made from the patients from private hospitals. So, as for dyspepsia, or known as indigestion, is persistent or recurrent pain in the upper abdomen. So, based on the case study, indigestion most likely occurred due to altered mucosa. Excessive consumption of alcohol and nicotine increase the sensitivity of the mucosa and stimulate more acid secretion. The signs and symptoms for indigestions are burning in the stomach or upper abdomen, abdominal pain, bloating, nausea, vomiting, and most common condition that interchangeable with indigestion is heartburn. So heartburn is burning pain behind breastbone. The stomach acid backs up into esophagus due to weak or relaxed lower esophageal sphincter. The signs and symptoms for heartburn are burning pain in the chest, pain worsen when laying down or bending over, and bitter or acidic taste. So as a summary, patient most likely to experience dyspepsia due to overproduction of acid. So we can see that patient complain of having upper abdominal pain. And then the overproduction of acid cause acid to start to flow backward into esophagus, and patient experience an episode of heartburn. So this also we can see that from the case study, patient said that the pain at first, he felt the pain at the upper abdomen, but then the pain is radiated to chest area. So other symptoms like headache, vomiting, and nausea also indicate to indigestion and heartburn.
Okay, continue to the management and outcome. The management that was done to the patient during his admission to the ETD is ECG was taken due to patient verbalizing that he is having chest pain, and IV ranitidine 50 mg, IV IM Buscopan 20 mg, and serum MMT 20 ml was given stand dose. And 30 minutes after the treatment, the patient verbalized that his pain score reduced from 4/10 to 1/10. Therefore, the treatment was terminated. Before being discharged, patient was given tablet MMT 2 tablet, tablet paracetamol 1 gram, tablet Buscopan 10 mg, and he was advised to control alcohol intake and stop smoking. He also advised to come to ETD or OPD if his sign and symptom worsen, especially the headache, nausea, and vomiting.
Hello everyone, I'm Nuris Mahadisa. So today I'm going to present about the nursing captain for this case study. So I developed two nursing diagnoses with the nursing goals and nursing interventions with the nursing evaluations for the two nursing diagnoses that I already did. So the first nursing diagnosis is acute pain related to inflammation and irritation of stomach lining secondary to dyspepsia, as evidenced by patient verbalized abdominal pain radiated to chest with a pain score of 4/10. So the nursing goal for this nursing diagnosis is patient will verbalize decrease in pain score from 4/10 to 1/10 after 30 minutes of treatment. And the nursing evaluation for this nursing diagnosis after the implementation of nursing interventions is patient able to verbalize abdominal and burning pain on chest area subsided with pain score of 1/10 after 30 minutes of treatment. So these are the list of nursing interventions that are being done in the ETD. The first one, the vital signs of patient being assessed as soon as patient arrive in ETD and not the elevation of the vital signs such as blood pressure, heart rate, and a pain score. This is to evaluate the pain status of patient, which the increase of the blood pressure, the increase of heart rate, and also the pain score will indicate the patient still in the pain. The second one is perform 12 lead electrocardiogram, which is ECG. This is to check any irregularity or any abnormality of the cardiac rhythm and activity as patient complain of burning pain on the chest area. The third one is to administer the anti-ulcer drugs such as ranitidine 50 mg intravenously. The function of the ranitidine is to reduce the acid production by stomach and promote the healing of the stomach healing. The fourth one is administer the antispasmodic drug for irritable bowel such as Buscopan 20 mg intramuscularly. This is to reduce the spasm of gastrointestinal tract and to relieve the bowel pain. The fifth nursing intervention is to administer antacid medications such as syrup magnesium trisilicate mixture, syrup MMT 20 ml stat by orally. This is to relieve the indigestion that patient have and the heartburn. 6. Reassess the patient's vital sign and the pain score. The vital sign that I mean is pain score, blood pressure, and also the heart rate 30 minutes after the treatment. This is to ensure that all the vital signs in the normal range and there is a reduce of pain score, and also there is no elevation of the blood pressure and the heart rate above the abnormal range, because this is help to evaluate the effectiveness of pain management. Last but not least is to instruct patient to take medication that prescribed by doctor after discharge from the ETD. This is to prevent the recurrence of pain related to indigestion and the heartburn, also to relieve the existing symptoms. So this is a second nursing care plan. Then the second nursing diagnosis is knowledge deficit related to lack information regarding disease process as evidenced by presence of preventable risk of indigestion, as patient verbalize drink alcohol occasionally and smoking. So the nursing goal for this nursing diagnosis is patient will verbalize basic knowledge and express understanding action regarding way to reduce acid reflux. So nursing intervention nursing evaluation after the nursing intervention being implemented is patient able to verbalize basic knowledge and understood the action that may help in reducing the excessive acid production. These are the nursing interventions for the second nursing diagnosis. The first one is assess patient's knowledge about his current condition and understanding on how the indigestion and heartburn occur. This is basically to evaluate the patient's basic knowledge and also to help in organized teaching plan. The second one is to provide patient with disease process information such as the risk factor and also factor that can trigger the occurrence of dyspepsia or indigestion in patient. This is to ensure that patient gain knowledge and prevent further indigestion that could lead to worse heartburn. The third one is advise patient on diet controlling and intake habit by telling patient to chew food slowly when patient eat while maintaining high protein and low fat diet, because if patient take high fat diet, it may cause patient injuries of developing the inflammation of stomach lining that could lead to indigestion. Fourth one is instruct patient to stop smoking, as he is heavy smoker, which smoker has high risk of getting dyspepsia. The reason why we tell patient to stop smoking, because to minimize the nicotine consumption that nicotine that has in the cigarette, which it may cause relaxation of esophageal sphincter and stimulates production of stomach acid. Fifth, advise patient regarding control of alcohol consumption and slowly stop consuming it as soon as possible, because alcohol may increase the acid production and may cause esophageal spasm. The sixth one is advise patient to reduce intake of spicy, citrus, and gas-forming food, because this kind of food will cause the excessive production of acid in the stomach, and that may lead to the heartburn and increased acid reflux. So last but not least is instruct patient to verbalize back about the information that given to evaluate his understanding about the disease, which also help in preventing recurrence of these symptoms of indigestion.
Okay, continue to discussion. Why patient's condition remains? It may be due to his non-compliance to medication, or it can also be due to his unhealthy lifestyle, which he verbalized that he's an alcoholic and an active smoker. What complication can come from dyspepsia? There are two, which is peptic ulcer disease and gastroesophageal reflux disease, which is GERD. Prevention needed is patient need to change their lifestyle to prevent recurrent symptoms and illness.
So the conclusion from this case study is that dyspepsia may cause the excessive amount of stomach acid production that may cause patient to have to experience upper abdominal pain, and if it worsen, patient may have a heartburn also. So for this case study, despite treatment over the years, presence of risk factor may cause dyspepsia to recur, which means even with the treatment, patient still has this kind of symptoms like the upper abdominal pain and also the heartburn, because he is heavy smoker and still has the alcohol consumption. So with this presence of risk factor, it causes a patient still has the symptoms of the indigestion. So last but not least is knowledge and also pain management is important to treat this condition. Thank you.